Thank you very much. It's a really special gathering and a privilege to be involved in this project. Now, I'm going to talk a little bit about the research background to the data that my colleague Yilam will follow on and present to you. I, in some way, following Danish's talk, my sort of identity is coming from the mainstream public mental health services. So I have for many years worked in developing early intervention services for psychosis in Hong Kong. Now, many of you here will not remember, but I hope some of you will be old enough to remember. There was a case that stuck in my mind, I think more than a decade ago. A Nepalese young man was behaving strangely in one of the abandoned public park. I probably remember that. And for I think more than a day, he was eventually approached by the police. He then behaved threateningly, and the police shot him mortally. Now, for me, it was very likely that this young man had a psychotic illness, was in the early phase of a psychotic illness. And we didn't know how to deal with a case like that. And the language problem, the cultural differences, and also mental illnesses and lack of knowledge and appropriate response to mental illness, all contribute to this tragedy. We hope that we have moved on in Hong Kong since then, but still in my daily practice in the hospital, so I run the early psychosis hospital inpatient team, we come across very, very few ethnic minority patients, fewer than we would expect. And in early intervention, we don't only focus on what we see in front of us, but we also ask, why are these other patients not presenting to our care? So in the few cases that we saw, they are very complex. And we are very much aware of the limitation of our teams in terms of language and culture to handle the complex family and cultural problem of our patients. So I am aware from the other end of what Salini talked about, of a huge unmet need. So when Salini and the Suen Foundation approach us to embark on this project, we are only too pleased to be involved. So the other sort of cultural identity that we represent is the more research, medical, clinical research sort of culture that would help eventually to link what is a very complex, as Denise has presented, problem to the maybe simplified sort of biomedical way of assessing outcome and so on. So this is what we are going to present to you in the next few minutes, or I'm going to present to you the technical aspect of the randomized control study. This is only a part of the picture, and we have done other study, and we're going to do other study to enrich this picture. But this picture is important to get the initial data of the effectiveness of the outcome. Here I just want to say lastly that this project, like many other projects in mental health, you basically only have time to set up the thing and to evaluate it at the same time, more or less, and there's not much room or time for getting things wrong. And I can still remember how the great pleasure, the pleasure that the team was under last year in the middle of COVID, struggling with recruitment and data collection, and then the funding running out. And thanks to the Lee Hai-Sen Foundation's understanding, we were able to continue so to be able to share with you the initial results. So may I ask Yilam to present to us the detail of the study. Thank you.
Okay, thank you very much. Actually, I have a few slides introducing the background of ethnic minority population in Hong Kong. But as Shalini has talked much about that, I will skip it for now. And I will jump into the method of the study. In the following 10 minutes, the methodology of the research and the result of the RCT study will be shared with you. The RCT study recruited participants from January 2021 and to August 2022. Other than participants who reached the Jubin Foundation themselves, the Hong Kong U team also connect ethnic minority participants from our other research projects, such as Level Mind at JC Women Project, as well as Headwind Project. Participants were randomly allocated to the counseling group and the waitlist control group. Participants in the counseling group will receive culturally adapted counseling service immediately after randomization. And other participants who are randomized to the control group will receive the counseling service after a period of monitoring call. For the counseling group, the participants receive culturally adapted counseling with CBT-informed framework, and participants who had mild to moderate level of mental distress will receive 6 sessions of counseling intervention in 8-week time, while those with more severe mental distress, will receive 10 sessions of counseling intervention for 12-week time. All counselor has the qualification of clinical psychologist, counseling psychologists, as well as mental counseling, and work with much experience in Hong Kong and ethnic minority population in Hong Kong. The training included a training by the lead counselor, as well as ongoing supervision by the lead counselor. The training manual will the training of the treatment manual has lasted for 2 days, and with the ongoing supervision. The lead counselor also received 1 to 2 session ongoing supervision by an external supervisor on monthly basis, while the control group will receive text-based and phone-based contact through the center for the monitoring purpose to make sure that any urgent or deterioration situation will be handled and supported. And we expected that contact time will be less than 15 minutes every time. Here we have the inclusion and exclusion criteria of the study. Basically, only non-ethnic Chinese Southeast Asian residing in Hong Kong with age of 15 to 64 years old will be eligible for the study. They have to self-report at least mild level of mental distress as measured by the DAS scale Shalini has mentioned earlier. And they need to have sufficient proficiency in English, Hindi, Urdu, and Nepali in order to understand the verbal instruction. They also need to be able to provide informed written consent or parental consent if they age 18 or below. Several conditions may also exclude the participant from participating in this RCT study, such as if they are receiving psychiatric or psychological treatment outside the center, or if they have substance abuse issue, or they have active suicidal ideation or engage in self-harm behaviors. The primary outcome of this study was the changes in depressive symptoms, anxiety symptoms, and stress level measured by the DAS subscale from baseline to time 1, which is after the counseling session of the intervention group and after the monitoring call period of the control group. The secondary outcome was the changes in mental health-related quality of life measured by the mental component score of the 12-item short form survey version 2. The current study randomized participants on a 1-to-1 ratio using permutative random block size of 4 and 8 and stratified by the participants' distress level. As all outcome measures were self-reported, there were minimal assessor bias, and the randomization was conducted by a computerized system so that investigator and research staff in the study did not know the group allocation before randomization in order to achieve the group allocation concealment. The current study adapted an intention to treat plus last observation carry forward approach as the primary analysis strategy. The between-group differences of the outcome measure at time point 1 was examined using multiple linear regression. In the model, the independent variable is the RCT group assignment, and the dependent variable was the score of the outcome measure at time 1. The models were also adjusted for the baseline variables, which were found to be significantly different between the two groups, which include duration of stay in Hong Kong, perceived social support from family and significant others, as well as the cultural orientation implied. Sensitivity analysis was also conducted using ITT and multiple imputation approach, per protocol approach, as well as subgroup analysis approach. So here we come to the result of the study. The console flowchart has illustrated that the whole recruitment process has reached 204 participants in 20 months of recruitment period, in which 120 enrolled in the RCT study. About half of the participants who were excluded were ineligible for the participation, such as having psychiatric service or psychological intervention outside the center, as well as with suicidal risk, and another half were not able to complete the baseline assessment. Among 60 participants who were randomly allocated to the counseling group, 53 completed the intervention and time 1 assessment, and all of these 53 participants also completed booster in the sessions and the time 2 assessment. Among 60 participants who were randomly allocated to the waitlist control group, 57 completed the monitoring period and time 1 assessment, but only 43 completed the counseling and booster sessions. Participants in the current RCT study were mostly women with an average age around 30. More than half of them received post-secondary education. The major ethnicity was the Pakistani, followed by the Indian. And they were mostly either housewife or employee. About half were married and have at least one child. Most of the participants had a monthly household income above 20,000. About half were living in public rental housing, with an average household size of 4 to 5. Of note, about 1/3 of our participants were born in Hong Kong. The participants, on average, have staying in Hong Kong for 17 or more years, but the control group had a shorter duration of stay compared to the intervention group. The initial assessment found that participants had moderate level of depressive symptoms, severe level of anxiety symptoms, moderate level of stress level, and mental health-related quality of life below the norm of Hong Kong people. Other psychological measures revealed that the randomization of the participants has been done quite well, except that the control group report more social support from family and significant others, as well as a cultural orientation in pride. From this slide, you can see that the participant in the counseling group, which is illustrated by the black solid line, demonstrates significantly greater improvement in their depressive symptoms, anxiety symptoms, stress level, as well as mental-related quality of life. While the improvement is considered in a categorical way, 43.4% to 58% of the intervention group had reliable improvement, compared with 15.8% to 17.5% in the control group. The statistical testing showed that the greater improvement in the counseling group were statistically significant, no matter it was performed through ITT plus last observation carry forward approach, ITT with multiple imputation approach, or per protocol approach. We have also repeated analysis in a series of subgroups aiming to see whether the intervention was benefit or not benefit to any subgroup. The findings suggested the effect remained robust in most subgroups except among those with lower rumination and better help-seeking attitude when encountering suicidal matters. Of note, Our findings do not demonstrate sufficient evidence of presence or absence of effect in suffering subgroup with small size, such as male group, or those group with higher cultural orientation in pride. Overall, we found that the counseling effect was better in the intervention group in terms of mood symptoms. Our study provided evidence that low-intensity intervention counseling featured with cultural sensitivity is benefit to ethnic minority participants in Hong Kong. However, the study also encountered some challenges. For example, 1/10 of the screened participants were not able to be recruited to the study as they have pre-existing suicidal risk, but referring them to the existing public service is still difficult due to stigma. Also, as the study was conducted during the outbreak of COVID-19, our service is also burdened by the extra COVID-related stress problem on top of participants' pre-existing mental distress. There is some study implications. The EM Wellbeing Center organized by the Jubin Foundation has successfully engaged in ethnic minority with mental health need and improved their mental health through providing culturally sensitive CBT-informed counseling service. The effectiveness is generalizable to ethnic minority with wide range of background. On one hand, the model engaged in ethnic minorities with substance distress level, preventing them from further deterioration. Also, it connects neither ones to the existing public service. The service model should be considered for more ethnic minority platform in Hong Kong. So this is my presentation of the RCT study. Thank you very much.